be speaking about a very new and exciting topic, which is the integration of immunotherapy into our management of resectable lung cancer. And I'll first tell you why as oncologists have been very excited about this development. Historically, and until very, very recently, when we thought about lung cancer that could be removed surgically, the really standard thing was we did surgery up front, and then we followed it up with a course of we called postoperative or adjuvant chemotherapy. And this does improve outcomes and it reduces risk of disease relapse, improves what we call chance of survival at 5 years by about 5%. So people are benefiting from this, but not as much as any of us would like. And we know that for even resectable lung cancer, there's still very much a real risk of tumor relapse. Looking at 2/3 of patients by 5 years, and 1/3 of patients by 5 years for stage 2 cancer, and 2/3 or more with stage 3 cancer by 5 years. So there's risk here that we want to try to reduce for our patients. And preoperative therapy has become one tool to try to achieve that reduced risk of tumor recurrence. And what are some of the goals of using additional therapies in the preoperative setting? So you can hope of taking maybe a tumor that's a little too big to remove safely, try to shrink it, and convert unresectable to resectable disease, so make surgery possible. You can try to reduce the extent of surgery needed, maybe reduce from needing a whole lung removal to just one lobe of the lung, so you preserve more healthy lung and reduce the potential extent of recovery needed from surgery. You can increase the chance of trying to get a complete resection, which means there's no residual cancer, either to the surgeon's eye or under a microscope in pathology. You can get information from that sample once you take it out, once you remove the lung after treatment. You can look at those tumor cells and say, how well did my preoperative treatment really work? How many cells appear to have died? And we hope by doing all this, you could improve survival, reduce risk of relapse, or change how the cancer and the body are interacting to modify that cancer biology. There are several tools we have available that have all been studied initially in the metastatic setting and are moving up into that surgically resectable lung cancer. So chemotherapy is familiar probably to many of us here. Those are infusional therapies, usually for lung cancer. Historically, we've given them after surgery, but certainly they can also be given pre-surgery, trying to reduce that risk of relapse. Like I said, maybe about a 5% benefit there to doing that. We also now have the world of targeted therapy for lung cancer. These are usually oral drugs or pill-based therapies, but they're really targeted to very specific gene mutations in cancer cells. I'm not going to talk a lot about targeted therapy in the surgical management of lung cancer today, except to point out that there are a lot of clinical trials ongoing right now, looking at using targeted therapies before or after surgery for all these different gene mutations I listed there, and some which are approved, for example, for EGFR. But the therapy we're going to focus on today is really adding immunotherapy into this treatment strategy. Of course, these are infusional therapies. They've been approved in the metastatic setting now for many years in lung cancer, and they help the immune system learn to kill cancer cells most effectively. These are right now in lung cancer, usually what we call PD-L1 or PD-1 inhibitors. You can see in that little diagram there, the signal between PD-L1 and PD-1 sends a shutoff signal to immune cells, preventing them from killing the cancer cells. By blocking that signal, you can help the immune system activate and kill the cancer cells on your behalf. So that's how these therapies work. And that's why this PD-L1 level on the tumor cells, because it's the target of the therapy, can be important in understanding probability of the treatments working. So in the metastatic setting, we've known now for some time that adding immunotherapy to chemotherapy, giving them in combination, is more effective than chemotherapy alone. This is from one of the big original studies called the Keynote 189 study that looked just at doing this. They randomized people to chemoimmunotherapy or chemotherapy, and they showed that by adding immunotherapy, on average, people were living longer and having a better chance of tumor response, tumor shrinkage on therapy. So average survival time improved by almost a year, and the fraction of people living at 2 years almost doubled. And now you can see that on the survival curves there to the left. And our audience may have a mixed group here today. I don't know how much experience you might have looking at survival curves, but it's something that is often used in oncology presentations and papers to try to explain how well a treatment is working. I'm going to run through an orientation on that here for you today. Use the example here, relapse-free survival after surgery for lung cancer. You can look on the y-axis there, the percentage of people who are currently living without a cancer relapse after their surgery. The bottom is over time. And you can see if over time the number of people who are free from cancer drop off, you show that's kind of a worse outcome. You're seeing most people are having a cancer recurrence in this example. And then as the curve moves upward, you could get to a perfect outcome, which is a straight line across the top, which means all patients are remaining cancer-free for the entire study period. Now, usually our studies look more like that yellow line where we're trying to shift that line upwards. You can see that's what happened here in the keynote study, where the blue line, which is the immunotherapy arm, did better than the red line, which is the arm that was chemotherapy only.